Health inequalities is a difficult nut to crack, isn't it? Those people who live and work in areas of high deprivation have the worst health outcomes. And there's lots of factors that contribute to it, in addition to the quality of the healthcare and the level of access that they have to it. Wouldn't it be great if a group brought together all of or a lot of the research in the area and provided a toolkit to enable people to look at the health inequalities affecting their populations and effectively design an intervention? Well, some people have done just that, and we're going to have a look in this episode of EGP Learning. And welcome. Hi, Gandhi. How are you doing this afternoon?
Yourself, Andy?
Yeah, I'm pretty good. So we both work in areas of high inequality and deprivation. So we've had a lot of contact with this topic of health inequalities. And I don't know about you, Gandhi, but it always feels like it's really difficult to make a difference and to know how to do sort of new things, or develop an approach that might be effective for the population in your area. Are you finding it difficult to crack?
Yeah, I mean, it's challenging, isn't it? We're at a point in the financial situation where resources are tight, and the reality is when you're looking after health inequalities and that kind of stuff, you need resources to help. And unfortunately, those may not be available, which is a difficulty. And then it's how do you help those people, the most deprived areas and stuff. And deprivation is a different aspect of health inequalities, but it compiles into it. And it's a question of what do you do to help as many people as possible to have equitable healthcare.
Yeah, so I mean, I'm involved in a few groups locally. I'll give a shout out to the Deep End group in Nottingham, Breakfast Club, 8:30 on a Tuesday morning, once a month, talking about how to try and tackle this problem. And NCGPA and the collective primary care networks together are trying to do things to help with significant multiple disadvantage as well. But it can be really difficult to kind of know where to start, as a practice or as a group of practices in terms of doing something effective. So there's some research that was published recently. Shall we just pop that on the screen, Gandhi? You okay to?
Yeah, let's go for it.
Just link. So this is, people can look in the show notes, but this is the website where it's based. So it's from Queen Mary University in London, and they've done some work bringing together their own Equalise research together with some work done in a Fair Steps study in Sheffield, to develop a sort of a slide deck which articulates and sort of demonstrates a framework that people can use to think of ideas and come up with effective ways to address this. So let's have a look. So if you download the slide deck from that website, there's lots of really good slides that can help you as an individual or group make the case for health inequalities, and then also lead some discussions around what might be useful things to do. The executive summary on slide 2 is really, really good, Gandhi. So they've looked at the Equalise study, which is their research from St Mary's, which has identified the 5 guiding principles which mark equitable general practice. So they're saying when general practice is doing well in addressing health inequalities, they generally see that it is doing these 5 things. So that's.
Can you zoom in a little bit, Andy, so we can see that a bit clearer?
In fact, there's a better slide further down. There's lots of slides that make sort of similar points in similar ways. But here we are. So when we're doing it well, so services are connected. So they're connected and coordinated. They mention. In fact, let's go back up to the other slide. I think I prefer that. They mention intersectional. So intersection, it's a bit more of a sort of popular concept now, isn't it? But that's where people have, obviously we all have different characteristics, but some people have a certain combination of characteristics. So they might be, they might have mental health problems, and they might also be, a refugee, and they might also be a vulnerable female, for example. And that intersectionality can put people at much greater increased risk of suffering health inequalities or poor outcomes in their health. So they think that we should be paying attention to intersectionality, should be flexible, so making allowances for different people's needs, should be inclusive. So they talk about the culture of an organization being an inclusive one, not prejudging people, not necessarily being too dominated by sort of Western cultural medical or cultural values, and they talk about being community-centered. as well. So really involving people in the community in the design. So do you see a lot of that work going on, Gandhi? You do a lot of work in general practice.
Yeah, so I don't see as much as I guess I would like. I think there are definitely aspects of having connected community care that can be really powerful, and we're trying to do some of that. I think with our PCN as well as other initiatives and stuff. I think inclusivity, places try to do that, and that occurs differently. Intersectionality, I must admit, I've not heard that term before. So it's really interesting to hear how it's characterized, and I can definitely see the power of understanding that more effectively, and also targeting those patients who are at those intersections of different healthcare needs and stuff. Because you're right, they're the ones that possibly are easy to miss, but also probably the most vulnerable out of the lot.
Yeah, and you don't always see it because often you're seeing someone because they are perhaps there's necessarily domestic violence, but you don't
Yeah.
necessarily understand the other factors that might be adding to their vulnerability. So being aware of just the concept to begin with, and then also being curious about the rest of the person's life, can be helpful. And also some people will share intersectionality and be present in particularly vulnerable communities. So so part of the toolkit is about is approaching this with a mindset of identifying what can we do with our limited resources to have good impact. So in terms of identifying where to focus to have a high level of impact on outcomes for people, that concept of intersectionality might be really important, for your community. So so those are the 5 guiding principles. And then from the other bit of research from Sheffield, they were focused on the steps. I think that might be better represented a little bit further down. So this slide is really, really good because this kind of pulls it all together. You've got your 5 principles here. You've got your 4 steps from the Sheffield research. They say define the groups, consider the issues, ensure key ingredients, and co-design the intervention with the population. And that sounds really obvious, but if you are trying to guide a group of people through a discussion to decide on something impactful to do, you do need to structure it in some way. So this is where these slides, I think, are really, really helpful and show that you're drawing from a toolkit. And then the new thing, Gandhi, which seems to be emergent from this work of bringing it all together, is this concept of the action areas as well. So you might sort of identify, your group and consider the issues and show the groups, but at some point you've got to decide what are you going to do, and this gives you a way to think about the areas in which you might take action. And it uses this wheel, which we'll kind of see later in the toolkit. But they talk about you could have action on structures and policies. So how services are structured, how they work together, and certain policies. So some of the case studies talk about registration policies and things like that, and the requirement for identification and how that can be a barrier to certain populations. So simple changes in policies can improve general practice's responsiveness to people suffering disadvantage or inequality or multiple deprivation. So they talk about structures and policies, ideas and knowledge, organizational practices. So that's not the general practices themselves, but the doing. Just what do people do within the organization? And then they talk about relationships and communities. So, but I thought that was a really good way of actually thinking. Actually, if we're going to do something, where do we focus on? So I thought that was really powerful. You begin to see any ways to apply this, Gandhi, as we're beginning to go through?
The mind's ticking. I think I'd like to hear a bit more though, because I know that there's some other things they recommend later down the line that probably are more practical.
Yeah, so the recommendations bit, we'll get there in the end, but they make some recommendations of things they've come across throughout their research for different levels of the NHS, from commissioners, to individual practices, and that's really, really interesting. So, so there's some good slides as part of the slide deck, that you can use if you're leading a group through this process. I think actually, just to go back to the beginning, there are a few really good slides. If you want some really good slides to summarize the problems of health inequality, and maybe people are watching this video not aware of some of these principles, but if you think about things that determine the length of people's lives and how long they live in health, actually only I think it's about 10, 15, 20% of that is determined by their access to healthcare. The other 80+% is determined by things like their education, their environment, the quality of their relationships in their community. Do they have access to good quality food? All of these things. And there are some good slides, out there about that. But this just highlights the differences between the rich and the poor, for example. So, access to good quality jobs, and enough money is a big factor. So this just makes some points around the difference in life expectancy between rich and poor, and your likelihood of smoking, whether you have a professional or a manual job, for example. And then this one talks about the inverse care law. Friend of the podcast, the inverse care law. The access to good quality healthcare is inversely proportionate to their people's ability to access it. May have butchered that a little bit, but basically, those people who are able to access healthcare well tend to be the people that need it the least, and the people that need it the most tend to be the people that have difficulty accessing it. And there's some good points about availability of GPs per 10,000 population, based on whether people are in the richest part of society or the poorest. So, but those concepts are friends of the.
That's a challenge you and I both know quite significantly, isn't it, given our geography? So I know for a fact that where my practice population is a mile down the road, there's nearly double the number of GPs in compared to the practice population I work in, compared to the practice population I live in. And that's,
I was going to say that, I mean, we're two GPs sat here, but we work in deprived areas, and I guess we live in less deprived areas where there is much greater access to people like ourselves, to GPs. It's a sort of strange irony in a way, isn't it? So just moving through so this, I think, is a key slide that kind of pulls a lot of the principles together, actually, this vision slide. And then they talk about this well. So there's a number of good case studies in here. I want to move on and talk about the priorities and the recommendations later. So we won't go into detail on the case studies, but people can have a read. And they look at things that have been done in these action areas. So they look at some examples of things in structures and policies. They look at some of them in ideas and knowledge area, organizational practices, and I think there are some ones that are there in the interpersonal area as well. But they're really good, and have a look at them. There we go. Relationships with communities, which is sometimes appears as interpersonal. But Gandhi, I think we should have a look at the recommendations, because I think that might generate some discussion.
Let's take a look, shall we? Yep.
So, actually, just highlighting, they link out to the Safe Surgeries toolkit, and then they summarize the approach here. But this is a kind of toolkit that surgeries can apply to take some positive action on health inequalities, and they link out to this, which is provided by Doctors of the World and recommended by St Mary's University in London, who are the authors of this this slide deck and pulling these studies together. So the recommendations, these are really interesting. So through pulling things together, they've come across a number of different things that have been suggested or tried, and they pull them together in recommendations for different, parts of the NHS. So they talk about primary care commissioners, they talk about networks and practices, and they talk about education and training providers. And they use one of these prioritization grids, which I think we've talked about in some of the episodes in the past about productivity. So this is a variation of that. So they've got two axes. They've got things that they think are the most useful or more useful, and things that they think are less useful, because I guess they're reaching the judgment that it's all useful in some way. And they talk about things that are harder to do and things that are easier to do. So if you're going to have a conversation with your primary care commissioners, perhaps you're a group of deep end practices and you want to suggest something that will be high impact and easier to do. For those on the podcast, I'm using my my quotation fingers, because I'm not quite sure how easy some of these things actually are. So the most impactful thing for primary care commissioners would be funded program of extended consultations for patients with complex needs, supported by multidisciplinary team meetings. So, I mean, it doesn't sound too easy to put in place, but one can see how that would be impactful. And actually, drawing from some research in a toolkit to reach that conclusion, is stronger than just coming up with it yourself, I guess. And I guess the idea is you would have applied the toolkit and hopefully arrived at at some of these as well. Yeah. How possible do you think that might be, Gandhi?
Well, I'm surprised that that's in the easy to do category, if I'm being honest.
Yeah.
It definitely sounds like it'd be useful, don't get me wrong, having more time to dedicate to these patients with, complex health challenges and significant needs, but trying to facilitate a multidisciplinary long period of time for, in some ways it's easy to do because you can just say do it, but actually the resources to enable that to happen is the challenge obviously with that, and that's I think the part we would struggle to do, because then the obvious question is what do you do about the stuff you have to stop doing in order to provide that, unless there's a resource increase, which we're not really seeing, isn't it?
Yeah, it's difficult, isn't it? And you almost think, well, maybe our commissioners have had a bit of sight of this or some underlying research, because I guess, in theory, we have the significant multiple disadvantage local enhanced service in Nottingham, which provides for, additional attention on those groups, and possibly, double or longer appointments and easier access. And then we've got, the Change in Futures program, which people can be referred into, although the criteria are quite tight in terms of they have to meet their definition of significant multiple disadvantage, which is quite tight to get patients that meet that. And they do have a wraparound MDT approach. So some things are there, but they're not that widespread, and they're focused on quite a narrow population. To us, so if you look at sort of what's harder to do but impactful, funded 2-year program for extended consultations for practices registering new refugee and asylum seekers with additional needs. And again, I think we've had a les around asylum seekers in Nottingham as well,
We
but
have.
you will get more. We don't get so many where we are. So some of these programs do exist, and I guess that's where they've drawn their research from. So those sorts of things for primary care commissioners.
Just before we crack on, Andy, it may be worth just looking at something that's useful to do but easy to do. So
yeah,
I don't know. We looked at really useful and easy to do, but how about having a look at useful to do but
useful but easy? Okay,
useful but easy.
So, support for isolated elderly patients from underserved groups in accessing healthcare appointments and engaging with community resources. Sounds a bit like social prescribing, doesn't it?
It does.
In a way, maybe with an element of transportation involved.
So interesting. I know some practice populations where that's what practices have done. They've created their own kind of like non-urgent ambulance service to transport patients around to support them.
Yeah,
maybe
that sounds really innovative. Be interested to know how. Do you know how that was funded, Gandhi? Where they?
I think they've got the PPG to support it, so it's actually run by volunteers.
Okay, that's fantastic.
Were they still running? So this was something that was pre-COVID. I don't know if it's still running post-COVID, because obviously that was one of the things. But yeah, was that somewhere in London? I can't remember which practice.
Yeah, it almost sounds like it might be an area that might be more affluent. Those tend to be the areas that can draw.
I would agree with that. Yeah.
I would agree with that. Definitely an affluent PPGs. Area. People in PPGs tend to have more personal resources and time and experience in these things to do that in those areas. Although it could be an area of London with with quite a tight knit community, as well. Maybe. I can imagine it working with quite tight knit kind of community or religious community. That might support those kind of activities. But if you've got those resources in your area, great. Work with them.
Well, I think if you're watching this and listening to this and you have got all those resources, let us know in the comments. We'd be keen to know about it and share it potentially. So yeah.
It's great to share good practice.
Definitely.
Let's have a look networks. At networks and practices. So this is kind of the level that I guess maybe most of us watching this are operating at. So easy to do, most useful. So they suggest a safe surgery initiative, ensuring migrants and other groups are aware that care is available without ID and interpreters are available if required. Multilingual promotion of cancer screening for non-English speakers, including computer prompts for practitioners to signpost. So sounds quite achievable, actually, at a practice level. You need some resources to pull it together, and you have to kind of generate that will across practices to actually engage with the initiative, which can be difficult when people are overstretched. But that seems quite good. I guess I'm going to look at the other end of the spectrum, because that's always tempting, harder to do and less useful. Weekly weight loss group coaching programs targeted at people with low incomes. Actually, we're beginning to do that with our health and wellbeing coaches. In my primary care network, so it's not necessarily that difficult. But there's lots of good good examples on here. I quite like the group health coaching appointments for underserved groups. I think that could be really really good. Looking at something that's harder to do but more useful, like we did with the other, so welfare advisors on hand to assist with benefits for patients and carers on low income, including drafting letters and appeals. And I'm thinking, we've got a financial wellbeing social link prescriber now in our area. So
same here.
Actually looking at this, it does sound quite encouraging that some of these things are becoming a reality through primary care network funding. That's really, really positive. And then the final area that they look at is education and training providers and what they can do. And I think this is quite interesting because it's not something that you might immediately think of, depending on who's making up your kind of group of people looking at the health inequalities in your area. But they're suggesting as easy to do and useful as structured postgraduate training programs for GP specialty trainees in underserved areas. So I guess we've got Trailblazer Fellows, haven't we, in Nottingham, who are post-qualification GPs who have some funded time to do projects looking at health inequality related issues and are encouraged to work in areas of higher deprivation. So that sort of thing is beginning. And I guess, these things can always be expanded and supported better and protected from funding cuts. I quite like the idea of actually just raising the profile of health inequalities in general in health education and training, and maybe even getting into medical schools, to give people exposure to people working in areas of high deprivation, to demonstrate that it can be really impactful, it can be something to aspire to do, and to give people contact with people with lived experience of deprivation as well, because medical students can sometimes come from quite sheltered lives, not always, but it's good to broaden people's experience at an early stage in their career. Harder to do, less useful, series of blended learning sessions for staffs focusing on one particular underserved group. I guess something so narrow might be quite difficult to get buy-in with. Yeah.
And then in the useful but easier to do, you've got, what was it on? I can't quite read it, Andy. Online something or other.
So useful but easy. Yeah, that's a good one. Online learning modules for primary care practitioners on healthcare needs of underserved groups. So, and again, that's present in Nottingham. The practice development unit offer training on trauma-induced. Oh gosh, I forgot. Pie and tick training. I'm drawing a blank on what that stands for. Psychologically informed environment and trauma-informed care. I do know that because I've been doing a bit of work around it. So that sort of training is quite useful as well. So and then national policymakers don't quite get off lightly, and they say that it should be high on. It should maintain a high level on the national agenda and priorities. For example, so they do make some recommendations. They're not in a grid to those other areas. So I'm going to kind of take the slides off screen, Gandhi, and I guess get your reaction to the toolkit itself. I think it's something that can really help people make a start in how they think about and how they structure interventions in areas where it can feel like it's difficult to know what to do or make an impact. So I think it's a really useful toolkit, and I encourage people to take a look via the link and use those slides to inform about the issues and structure discussion on interventions. But what did you make of it, Gandhi?
So I guess Andy spent a lot more time with this toolkit than I have, and as you can tell, because he led us through the document. Having said that, I think it's a really well-formed document. If you compare that to, say, for example, the 30 to 150 page plus documents that Andy and I commonly review, for example, last week we covered the the winter access plans and stuff, and obviously previously we've done much bigger documents. This is much easier to read, much more practical in terms, I think, of some of the outcomes that it recommends. That those 3 slides on recommendations, really handy to give you some conceptual ideas of how to possibly bring things to your local area to tackle the health inequalities and stuff. And I really like that approach, that particularly, that framework of, useful, more useful, easy, hard. You can just see what may be more comfortable to achieve, or what may be actually giving you a bit of challenge, but potentially some real benefit and stuff. So I like the way it's structured. I like the way it presents the information. I think it's a really good document, to be honest. I am interested to know how this compares to the Core 20+5 initiative, which is obviously one of the big ones around tackling health inequalities generally. And I think you said that this has a slightly different framework, which was the I think you called it something else, 5-4-4 or something.
5-4-4. They don't say that, but I just noticed that that's what it is. So the 5-4-4 approach. I think they're looking at different things. I think the Core 20+5 is talking about the clinical areas to focus on, and this is more talking about the approach to take in deciding kind of specific schemes to do. So I think they'd be really, really complementary. And I'd actually say I like that they've provided a slide deck for this, because in terms of cascading information to teams and pulling things out to show people and make the document really useful, that's a really, really good approach. So I would encourage other people in NHS England potentially to produce some slide decks to go out alongside their other publications. I think that's a really good approach. Yeah, I mean, on that note, I other than encourage people to look at the document, I don't really have anything else to add. Anything else, Gandhi, before we wrap up?
No, I think definitely recommend people have a look at the document. We'll put the links to that down below as ever, so it'll be in the show notes and stuff, whether you're listening to us on the podcast or whether you're watching us live. Just a reminder, this is going out at our newer time in terms of 8 o'clock, going out for our live streams on Thursday evenings. Next week, you are definitely want to join us live. We are covering something that is a classic challenge in primary care. And if you're a GP or a clinician working, you are definitely want to join us live for this particular document, because I think it's going to be quite controversial in terms of the guidance it suggests and the actions this therefore has, not only for clinicians, but absolutely for patients and for other sectors as well. A little bit of a sneak peek, and if you want to see that, make sure you stick around for the end of this one, so it'll take you towards it if it's already gone live. If not, it's probably coming up around about here. There you go. And as always, we're going to be here to help tech enhance your primary care and learning, and we will catch you in that particular episode. See you then.